Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Imagine a healthcare system where distance simply isn't a barrier. A world where cutting-edge technology brings medical expertise directly to you, whether you're in a bustling city or, miles from the nearest clinic. This isn't some far-off sci-fi fantasy. It's the rapid, transformative evolution of telemedicine we're seeing right now.
It's truly remarkable, yeah. Today we're taking a deep dive into this profound shift in healthcare delivery, focusing entirely on telemedicine. You might associate it purely with, the recent past, but we're going to uncover how a global crisis truly accelerated its journey from a niche, sort of futuristic idea to a fundamental part of modern medicine.
Right. So our journey today will take us from telemedicine's surprising history through its many forms and applications in the present, and then really zero in on how the pandemic transformed everything, the good, the challenging, and what's next for this truly hybrid future of healthcare.
Exactly. For this deep dive, we've pulled our insights from a really comprehensive research paper. It gives us a holistic, and I'd say critical, view of this paradigm shift. We've basically distilled the most important nuggets of knowledge and surprising facts to get you quickly well-informed, cutting straight through the noise.
Okay, good. Because it's easy to think of telemedicine as a very modern concept, tied to fiber optics and video calls. But you mentioned its roots go way back, really a long history of adapting communication to overcome distance. Can you take us back in time? I mean, how far does this concept truly stretch?
Oh, it stretches back much further than most people realize. Right into the 19th century, actually. During the U.S. Civil War, they're using the telegraph for everything from ordering medical supplies to sending lists of casualties.
The telegraph.
Yeah. And believe it or not, as early as 1879, an article in Lancet, the medical journal, was already discussing the telephone's potential to reduce unnecessary physician office visits. I mean, that goal still resonates today, doesn't it?
It absolutely does. That's remarkable how early those ideas took shape. Even before proper phone networks, people were envisioning this. And it gets even more fascinating when you look at the early 20th century. Radio News Magazine in 1924 and Science and Invention in 1925 both featured illustrations of a radio doctor communicating with the patient using both audio and a live picture. They were essentially drawing video consultations decades before the technology even existed.
It's pretty wild. And what's truly fascinating is how quickly some of those visions began to materialize, even with what we'd consider, primitive technology today. The very first documented clinical use in medical literature, that appeared in 1950.
Okay, 1950. What was it?
It described the successful transmission of radiologic images X-rays, basically via telephone line between two Pennsylvania townships. And that project actually started even earlier, in 1948. This pioneering work in teleradiology was then quickly built upon by Canadian radiologists in the 1950s.
Wow. So from images over phone lines, we move into the dawn of actual video medicine and institutional adoption in the 50s through the 70s. The University of Nebraska really led the charge here, didn't they? Starting a landmark project in 1959.
They did. They used a two-way interactive television system to transmit neurological examinations.
Interactive TV for medical exams.
Yep. And get this. By 1964, they expanded that to a telemedicine link with Norfolk State Hospital, which was 112 miles away, providing everything from psychiatric consultations to speech therapy.
That's incredible for the time. It really prompts us to think about how these early ideas became practical. What about emergency care?
Well, for emergency care, in 1967, the University of Miami School of Medicine and the Miami Fire Department collaborated. They used existing voice radio channels, like the ones ambulances already had, to transmit electrocardiographic rhythms, ECGs.
Heart rhythms.
Exactly, from rescue units directly to Jackson Memorial Hospital. This allowed for earlier diagnosis and preparation for cardiac emergencies, a practice that's, pretty standard now.
Right, makes sense. And a surprising player in this early history was NASA, wasn't it?
Yeah, NASA. The National Aeronautics and Space Administration became a major driver of telehealth research because, fundamentally, they were tasked with monitoring the health of astronauts in space.
Right, remote monitoring in the extreme.
Precisely. And one really influential project was the STAR-PAY-HC program. That's space technology applied to rural Papago advanced healthcare in the 1970s. This connected residents of the isolated Papago Reservation in Arizona with specialists using microwave and satellite communications. Talk about bringing space-age tech down to Earth.
Seriously. But despite all these promising early demonstrations, the 1980s actually saw a slowdown, a telemedicine winter, you called it.
That's right, the telemedicine winter. Interest waned quite significantly, mostly due to prohibitive costs and, well, technological limitations. Things like expensive satellite links and coaxial cables were just too much. Many of those early grant-funded programs were simply phased out.
So it wasn't a lack of vision, but more that the tech just wasn't affordable or widespread enough yet.
Exactly. But thankfully, the revival began in the 1990s, and this was directly fueled by the digital revolution.
Ah, the internet arriving.
Right. The proliferation of the internet, coupled with advancements in digital compression and computing power, dramatically lowered the cost and complexity of transmitting high-quality video and data. It suddenly became feasible.
Okay. And this renewed interest led to some formalization.
Yes, very much so. It was formalized with the founding of the American Telemedicine Association, or ATA, in 1993.
Got it.
What's truly fascinating when you look back at this whole history is how it reveals a consistent pattern. The vision for remote care almost always came first. Decades, sometimes even a century, before the tech or the economics caught up.
That's a really powerful point. So the pandemic wasn't about inventing something new.
No, not at all. It wasn't about a new idea. It was the ultimate pressure test, the overwhelming imperative, really, to finally leverage technology that was finally mature and widely available.
So it wasn't innovation on the fly during the crisis, but rather a sudden, desperate need that finally unlocked the potential of what was already there, just waiting in the wings.
Perfectly put. It highlights how policy and real-world imperatives are just as crucial as the technology itself.
And that's a perfect lead-in to understanding the modern telemedicine ecosystem, which, as you said, is truly a versatile toolkit designed to meet a wide range of clinical needs. We can broadly categorize these modalities based on timing, data type, and interaction, right?
Absolutely. The first category, and maybe the one people think of most often, is synchronous, or real-time telemedicine.
Okay.
This involves a live, two-way interaction between a patient and a healthcare provider happening, right then and there. It's essentially the digital equivalent of a traditional in-person office visit.
So like a video call with your doctor.
Exactly. Primarily using video conferencing platforms and secure telephone lines.
I've certainly done that for a quick consultation. It seems excellent for urgent care things, colds, rashes, minor infections.
Yes, definitely. And it's become exceptionally well-suited for mental and behavioral health counseling. Also very common for primary care checkups or post-surgical follow-ups.
And what's interesting is the rise of facilitated virtual visits, or FEVs. Tell me about those.
Right, FEVs. That's where a patient might be at a local clinic, maybe a rural one, with a trained telefacilitator like a nurse or a tech. And that person uses peripheral diagnostic equipment.
Like digital stethoscopes or cameras.
Exactly. Digital stethoscopes, otoscopes, high-def examination cameras, and they transmit that clinical data in real time to the remote specialist.
Ah, so it bridges the physical exam gap somewhat.
It helps, yes. But a key thing to remember with synchronous care is that it requires scheduling, simultaneous availability of both people, and it's heavily dependent on good internet connectivity.
Right, which isn't always a given.
Which leads us to the contrast. Asynchronous or store and forward telemedicine.
Store and forward. Okay.
This is based on collecting and storing a patient's clinical information like medical images, videos, test results, clinical notes at one point in time, and transmitting it securely to a specialist for review and consultation at a later, more convenient time.
Ah, so you don't need to be online at the exact same moment. That offers a high degree of scheduling flexibility, I imagine.
Huge flexibility. And it's not dependent on real-time connectivity. This is particularly well-suited for specialties dependent on visual data. Think teleradiology for X-rays and CT scans, teledermatology for sending pictures of skin conditions, or telepathology for transmitting digital pathology slides.
Makes sense. And even modern patient portals and secure messaging systems kind of function this way, right? Like e-visit.
Absolutely. Sending information back and forth without a live interaction.
Okay, so synchronous, asynchronous. Oh, what's next?
Then there's remote patient monitoring, or RPM. This is quite different. It focuses on the continuous or sometimes intermittent collection of physiologic data from patients outside a traditional clinical setting, usually in their own homes.
So using connected devices?
Precisely. It utilizes IoT sensors, connected blood pressure cuffs, glucometers, weight scales, wearables, things like that.
This seems huge for chronic disease management, like hypertension, diabetes, or heart failure.
It's a game changer there.
Mm.
The data can be automatically uploaded to a provider's dashboard, allowing for proactive intervention. The goal is really to prevent acute issues, reduce hospitalizations, and empower patients in their own care.
That's a significant leap forward, proactive instead of reactive.
Exactly. And we can't overlook mobile health, or mHealth. This is a broad category, really referring to medical and public health practices supported by mobile devices, smartphones, tablets, wearables.
So, like all those health and wellness apps, tracking steps, nutrition, sleep, medication reminders.
Yep, all of that falls under mHealth.
Yeah.
And one other important modality, though it's less patient-facing, is e-consults.
E-consults.
This is where a primary care physician, a PCP, electronically consults with a specialist about a specific patient's care. They share clinical information and get expert guidance, often without the patient needing a whole separate specialist appointment. Streamlines things.
Okay, that makes a lot of sense for efficiency. So what does this all mean for us as patients or just for understanding the landscape?
Well, understanding these distinct modalities is crucial because it shows us that telemedicine isn't just one thing. It's definitely not one size fits all. It's truly a versatile toolkit.
Right.
And the choice of modality synchronous, asynchronous, RPM really depends on the clinical question, the patient's condition, the need for real-time interaction, and the type of data required for an informed decision. It's about using the right tool for the job.
Tailored care, essentially, which leads us seamlessly, as you said earlier, to the biggest catalyst for telemedicine's transformation, the pandemic.
Yeah.
Before COVID-19, telemedicine's role remained largely peripheral, didn't it?
Very much so. It was constrained by a really complex web of regulatory restrictions and, frankly, conservative reimbursement policies. Payers weren't really covering it widely.
Then early 2020 hit, and COVID-19 completely upended everything. That's when telemedicine's path changed dramatically. The shift was truly unprecedented, wasn't it?
Unprecedented is the word. Telemedicine claims, as a percentage of all medical claims, just skyrocketed from a mere 0.2% in 2019. Think about that, Tanny.
Wow.
To 15.4% in 2020. That's an astonishing leap in a single year.
15%? That's massive.
It was indeed. And the Centers for Disease Control and Prevention, the CDC, they found a 154% increase in telehealth visits during just the last week of March 2020 compared to the same week in 2019.
Just in that 1 week comparison.
Just in that week.
Yeah.
To put that in perspective, in early 2020, telemedicine visits were maybe 1% of total healthcare visits in the U.S. By April 2020, that figure had surged to nearly 50%. Half of all visits, virtually overnight.
Half. And providers had to scramble to catch up.
They did. The percentage of office-based physicians using telemedicine for patient care leaped from just 16% in 2019 to an astounding 80.5% in 2021.
80%. Now, you mentioned it stabilized after that initial peak.
Yeah. After the initial peak in mid-2020, utilization did begin to decline and stabilize somewhat. Though, and this is key, it remains significantly above pre-pandemic levels. For example, as of Q3 2023, telehealth volumes were about 55% below their pandemic peak, but still way, way higher than before 2020.
So not a temporary blip. It stuck around.
Exactly. This isn't a sign of failure. It reflects what's been called a rational market correction, a transition perhaps to a more value-driven model.
Right.
We've seen a concentration in specific areas, especially behavioral health, where it has proven highly effective and its use has largely remained very strong.
Okay. And that explosive growth was really only possible because of those sweeping temporary regulatory waivers issued during the public health emergency, right? That was absolutely critical in dismantling the old barriers.
It truly was. Couldn't have happened without them. For instance, the HHS Office for Civil Rights waived penalties for HIPAA violations against providers using everyday communication technologies in good faith.
Meaning things like FaceTime or Zoom.
Exactly. Apple, FaceTime, Skype, Zoom. Suddenly, those were okay to use, which dramatically lowered the technical barrier for both providers and patients. Huge deal.
And crucially, they removed geographic and site-based restrictions. That sounds important.
Oh, incredibly important. Pre-pandemic Medicare rules were very restrictive. They largely limited telehealth reimbursement to rural areas and required patients to be at an approved originating site, usually like a clinic or hospital.
Not at home.
Not at home, generally. The PHE waivers eliminated these restrictions, allowing reimbursement for services delivered to patients anywhere in the country, most significantly in their own homes. This was, by many accounts, arguably the single most critical factor enabling that surge.
Wow. Care at home suddenly became widely possible and reimbursed.
Precisely. And beyond that, waivers expanded patient and provider eligibility. Suddenly, telehealth access included new patients, removing requirements for a prior in-person visit. And they broadened the types of providers who could offer telehealth physical therapists, occupational therapists, speech-language pathologists.
So more services became available remotely.
Yes. And the Centers for Medicare and Medicaid Services, CMS, made the crucial decision to reimburse a broad range of telehealth services at the same rate as equivalent in-person visits, payment parity.
Paying the same amount. That must have incentivized providers.
Absolutely. And importantly, this included audio-only telephone visits, which was vital for access, particularly for people without good internet or smartphones.
Good point. Addressing the digital divide aspect somewhat. And let's not forget interstate licensure waivers.
Right. Many states temporarily waived or expedited pathways for out-of-state licensure, allowing doctors to see patients across state lines much more easily.
And the DEA relaxing rules about prescribing controlled substances remotely?
Yes. The Drug Enforcement Administration, the DEA, waived the Ryan Haight Act's requirement for an in-person medical evaluation prior to prescribing controlled substances via telemedicine. That was vital for continuity of care, especially for things like mental health medication or addiction treatment.
So when you look at all of that together, wow. The pandemic, in effect, forced this massive nationwide pilot program for telemedicine.
That's a great way to put it, a forced pilot program. And it demonstrated quite clearly that when the policy framework aligns with the technological capability, the healthcare system can adapt with remarkable speed.
Right. And this forced expansion has given us a really concrete understanding of telemedicine's real-world impact now. The evidence strongly indicates it delivers significant value, doesn't it? Especially in expanding access.
Absolutely. Expanding access is arguably the most profound benefit. Telemedicine serves as that crucial bridge for rural and underserved communities, helping overcome provider shortages and, just the sheer distance people might have to travel. Historical examples like NASA's STAR-PACE project and plenty of modern studies show its success in serving isolated populations.
Yeah, and it's also fantastic for elderly populations and individuals with mobility impairments, right? It just eliminates the whole logistical challenge of traveling to a doctor's office, allows them to receive care from home, supporting that whole concept of aging in place.
Definitely. And if we look at chronic disease management conditions like diabetes, hypertension, heart failure, COPD, telemedicine, especially using RPM and mHealth tools, provides a framework for continuous proactive care. Studies show it leads to improved medication adherence, better clinical outcomes, like better blood sugar control for diabetics, and significant reductions in emergency department visits and hospital readmissions. For instance, there's data showing a 15% reduction in ED visits for COPD patients using telemonitoring. That's a huge impact on both patient health and system costs.
15% is significant, and it has absolutely revolutionized mental and behavioral health care, hasn't it?
Revolutionized is not too strong a word. It allows patients to seek counseling privately from home, which helps address stigma. And it connects them with a potentially national pool of licensed therapists and psychiatrists, directly tackling those persistent provider shortages, especially in certain specialties or regions. That's a massive win for public health.
Definitely. Now, what about the economic side, the cost effectiveness?
Well, there are clear benefits for patients. Direct and substantial savings from eliminating costs associated with going to an in-person visit, things like fuel, parking, public transport, maybe childcare, plus mitigating lost wages from taking time off work.
Right. Those add up fast.
They really do. A UC Davis health study found telehealth visits save patients an average of $11 in direct travel-related costs and about 35 minutes of travel time per appointment. And on a national scale, one analysis estimated potential savings of up to $89 billion annually just in reduced travel-related lost income for patients.
$89 billion, that's staggering. And what about for providers and the healthcare system itself?
For providers and the system, benefits include potentially lower operational overhead for clinics and reduced patient no-show rates, which is a big deal for scheduling and revenue.
Fewer empty slots.
Exactly. And significantly, telemedicine can help divert patients from more expensive care settings. It can help prevent unnecessary emergency department visits and reduce hospital admissions and readmissions. Research actually shows some telehealth interventions can cut ED costs by over 30%.
Over 30%. But there's a nuance here, isn't there, about the total healthcare spending?
There is. The overall impact on total healthcare spending is still debated. There's potential for what's called induced demand, meaning because it's more convenient, people might use more services overall, even if each visit is cheaper or prevents a hospitalization later. So achieving system-wide savings requires strategic implementation, focusing on high-value applications, not just using it indiscriminately for everything.
Right, it's not a magic bullet for cost savings across the board.
Yeah.
It needs smart application.
Precisely.
Okay, so access, economics, what about the human element? Patient satisfaction, provider engagement.
Patient satisfaction is overwhelmingly high, really strikingly high. A major 2020 J.D. Power study rated overall patient satisfaction with telehealth at 860 on a 1,000-point scale.
Wow, 860 is very high.
It is. Higher than their readings for other healthcare interactions, and even higher than things like insurance and financial services. Other surveys consistently found satisfaction rates well over 75%.
And what are the main reasons people like it so much?
The primary drivers are pretty clear. Convenience, number one. The ability to receive care quickly, often same day for minor issues. And, as we just discussed, the reduction in travel time and all those associated costs and hassles.
Makes total sense. And what about providers? Are they on board?
Largely positive, yes. A 2022 American Medical Association, or AMA, survey found over 80% of physicians agreed telehealth improved patient access to care. And 62% felt their patients had higher satisfaction with virtual visits.
That's encouraging.
It is. Plus, providers also recognize the potential for improved work-life balance for themselves and potentially reduce burnout, which is a huge issue in medicine.
Yeah, absolutely. So if we bring this all together, the impact seems clear. Telemedicine's greatest value is realized not as a universal replacement for every single in-person encounter,
Definitely not.
but as a targeted intervention. For specific populations, rural health, chronic disease, mental health, and specific clinical scenarios where the friction of travel, time, cost, and stigma is highest. It's about that smart application again.
That's exactly the takeaway. It's a powerful tool when used appropriately.
Okay, that distinction makes perfect sense. But despite all these clear benefits, the long-term sustainable integration of telemedicine faces some pretty formidable challenges, doesn't it? Related to clinical practice, equity, security, regulation. And these are often deeply interconnected, as you pointed out earlier.
They really are. One of the core limitations, perhaps the most fundamental one from a clinical perspective, is what we can call the diagnostic dilemma.
The diagnostic dilemma.
It's the inherent inability to conduct a full physical examination without physical contact. You can't do palpation touching the patient or auscultation listening with a stethoscope or percussion tapping on the body. Those basic physical exam techniques are lost.
Right. You can see the patient, you can talk to them, but you can't physically examine them in the same way. How much does that affect diagnostic accuracy?
Well, there's research on this. A large-scale Mayo Clinic study looked at diagnostic concordance. Basically, did the telehealth diagnosis match a later in-person diagnosis? They found an overall rate of 86.9%.
Okay, 87% sounds pretty good overall.
It is good overall, but, and this is a big but, the accuracy was lower in specialties that are heavily dependent on that physical examination or specialized instruments. For example, otorhinolaryngology, ENT, ear, nose, and throat. It was only 77.3%. Also lower in dermatology and oral medicine.
Ah, okay. So specialties where looking closely or feeling something is critical.
Exactly. And this creates a tangible risk of misdiagnosis or delayed diagnosis for conditions that really need a hands-on exam or lab tests or diagnostic imaging right away. Think about most cancer screenings, routine vaccinations, or evaluating acute abdominal pain or chest pain. You just can't do those things effectively remotely.
Yeah, absolutely. There have been case studies highlighting errors, haven't there?
Sadly, yes. Instances where failures in remote monitoring or diagnostic errors led to adverse patient outcomes and, understandably, a loss of trust.
So what's the mitigation? How do we handle this limitation safely?
Well, it's absolutely imperative for healthcare systems to develop clear clinical guidelines, defining which conditions are generally appropriate for virtual care and which really require an in-person assessment. And critically, establishing low-threshold pathways for patients to be easily seen in person when a remote assessment is inconclusive or raises red flags. Patient safety has to come first.
That seems crucial for maintaining trust and quality. Okay, so diagnostic limits. What's another major challenge?
Another huge one is the digital divide. We touched on it briefly with audio-only visits, but it's a massive structural issue.
Right, the gap between the haves and have-nots in terms of technology access.
Exactly. It's the gap between individuals and communities who have easy access to modern information and communication technology and those who don't. And it's not just about having a device. It encompasses access to reliable, high-speed internet or broadband, and also digital literacy, knowing how to use the technology comfortably and effectively.
And these disparities fall along predictable lines, unfortunately. Socioeconomic, geographic, demographic.
They do, very starkly. Nearly one-third of rural Americans still lack broadband access. Older adults often have lower digital literacy, and smartphone ownership is lower too. Only maybe 55–60% of people over 65 own smartphones. And studies consistently show that low-income households and racial and ethnic minority groups report lower rates of broadband access and device ownership.
So how does this impact health equity? If healthcare shifts more online, who gets left behind?
That's the critical question. Studies done during the pandemic surge showed that telemedicine use was significantly lower among older adults, Black and Hispanic patients, and those with public insurance or lower incomes. These are often the very populations who could potentially benefit most from increased access to care.
Right. So shifting to a digital-first model without actively addressing these disparities risks worsening health inequities, leaving vulnerable patients further behind.
Precisely. Any long-term strategy for telemedicine must include targeted public and private investment. We need investment in broadband infrastructure, especially in underserved areas. We need programs for affordable devices. And we need community-based digital literacy training to help people get comfortable using these tools. It has to be part of the plan.
Absolutely. Equity has to be baked in.
Huh.
Okay, diagnostic limits, digital divide. What about security? Securing the virtual clinic.
Privacy and data security are huge concerns, naturally. When you're transmitting sensitive personal health information, or PHI, over digital networks, it inherently introduces risks.
Like what kind of risks?
Unauthorized access, data breaches from hacking, vulnerabilities related to patients using personal devices, or unsecured home Wi-Fi networks. The list goes on.
And this is where HIPAA comes in, right?
Exactly. HIPAA, the Health Insurance Portability and Accountability Act of 1996, is the primary legal framework governing health information protection in the U.S. It has two key parts here. The privacy rule, which governs the use and disclosure of all protected health information, and the security rule, which specifically applies to electronic PHI or ePHI. The security rule mandates specific administrative, physical, and technical safeguards that healthcare providers and their tech partners must have in place.
So using just any video chat isn't automatically okay anymore?
No. While the public health emergency waivers temporarily relaxed enforcement on the specific platforms used, strict HIPAA compliance is now required again. For telemedicine to be HIPAA compliant, providers must use technology platforms that have robust safeguards, like end-to-end encryption. And they absolutely must enter into business associate agreements, or BAAs, with any third-party technology vendors they use. That ensures the vendor is also legally obligated to protect patient data according to HIPAA standards.
Okay, so strict rules are back in place for security. That's reassuring, but adds complexity.
It does. And that leads us to the final and perhaps the most tangled set of challenges, the regulatory maze. Licensing, reimbursement, and this looming policy cliff.
Right, maze. Let's start with licensing. How does that work for telehealth?
It's complicated, primarily because medical licensure in the U.S. is state-based. Generally, a provider must hold a valid medical license in the state where the patient is physically located at the time of the virtual visit.
Where the patient is, not where the doctor is.
Correct. So if a doctor in California wants to treat a patient who's currently in Nevada via video, they typically need a Nevada medical license. Obtaining licenses for multiple states is administratively burdensome and costly for providers.
And those temporary waivers during the PHE that allowed easier cross-state practice, are they gone now?
Most of them have expired, yes. There is something called the Interstate Medical Licensure Compact, the IMLC, which offers an expedited pathway for physicians to get licensed in multiple participating states, but it's only a partial solution. Not all states are in it, and it doesn't cover all types of healthcare providers.
So state lines remain a big barrier. What about reimbursement policies? Getting paid for telehealth?
That's another huge variable. There's no single national standard. Policies vary widely among different payers, Medicare, Medicaid, private insurance companies. The key issues are coverage, parity, meaning does the plan cover telehealth services at all, and more importantly, payment parity.
Payment parity again, paying the same as an in-person visit.
Right. Does the insurer reimburse a telehealth visit at the same rate as an equivalent in-person visit? Without payment parity, offering telehealth services is often just not financially sustainable for many practices, especially smaller ones. If they get paid significantly less for a virtual visit, the incentive isn't there.
Makes sense financially. And this all leads to what's been dubbed the telehealth policy cliff. What exactly is that?
The policy cliff refers to the impending expiration date for many of the federal public health emergency waivers that enabled that massive telehealth expansion, particularly within Medicare. Congress temporarily extended these flexibilities, but the current extension runs out on September 30, 2025.
September 2025. So what happens if Congress doesn't act before then?
If Congress fails to enact permanent legislation, many of those key flexibilities could just disappear overnight. Things like the removal of geographic restrictions for Medicare beneficiaries, coverage for patients being treated in their homes as the originating site. Many of those could vanish. It threatens to roll back a lot of the progress made. It is worth noting, though, that Congress has made some exceptions permanent, particularly for behavioral and mental health services provided via telehealth under Medicare.
Okay, so mental health might be safer, but a lot of other telehealth access is at risk without permanent legislation.
Correct. And these challenges, diagnostic limits, the digital divide, security, licensing, reimbursement, the policy cliff, they're all profoundly intertwined. For example, diagnostic limitations might be exacerbated by the digital divide if a patient can't afford good video quality. Reimbursement policies definitely impact equity and access. Creating a sustainable future requires a holistic policy approach that addresses all these interconnected pieces.
It really sounds like a complex puzzle to solve for sustainable integration.
It is. But looking ahead, as telemedicine transitions from being primarily a crisis response tool to an enduring feature of healthcare, its future seems likely to be defined not by replacing in-person care entirely, but by a much more sophisticated hybrid model, one that seamlessly blends remote and physical encounters based on need and appropriateness.
A hybrid model, and this future will be powered by even more advanced technology, right? What's on the horizon?
The next wave of technology is really exciting. Artificial intelligence, AI, and machine learning, ML, are poised to revolutionize remote care.
How so?
By analyzing vast data sets for diagnostics, think AI reading medical images like X-rays or retinal scans with incredible accuracy. By assisting with preliminary symptom assessment through intelligent chatbots that can guide patients, and by providing predictive analytics to identify high-risk patients before they have an acute event based on their data patterns.
Wow, AI diagnostics and prediction. What else?
The Internet of Things, IoT, or more specifically the Internet of Medical Things, IOMT, will dramatically enhance remote patient monitoring capabilities. We talked about RPM earlier.
Right, connected devices.
The next generation will move way beyond just single-point measurements, like one blood pressure reading a day. We're talking continuous data streams from interconnected wearables, smart home sensors monitoring activity or falls, maybe even implantable devices constantly feeding back information.
Continuous data streams.
Yes, this shift from episodic data collection, like you only get data when you're at the doctor's office, to continuous data collection is fundamental. It enables a truly proactive model of care. And some people are even talking about creating a digital twin of the patient based on all this data.
A digital twin. That's incredible. Like a virtual replica for monitoring and testing interventions.
Potentially, yeah. It's still early days,
Yeah.
but that's the kind of concept being explored. And then there's virtual reality, VR, and augmented reality, AR.
How do they fit into telehealth?
They're set to introduce really immersive experiences. VR is already being used therapeutically for things like pain management, physical rehabilitation, and treating mental health conditions like PTSD or phobias.
Okay, therapeutic VR. What about AR?
AR, which overlays digital information onto the real world, think like those smart glasses concepts, holds immense promise for things like remote surgical assistance. Imagine an expert surgeon, maybe across the country, providing real-time visual guidance, like drawing instructions onto the view of a local surgeon performing a complex procedure.
Wow, telementoring for surgery using AR, that's pretty futuristic, but you can see the potential.
Absolutely. So if we connect all this back to the bigger picture, the most likely future isn't purely virtual. It's this hybrid model that intelligently integrates virtual and in-person care into a single, continuous patient journey.
Right. The modality for each interaction, whether it's a video call, an in-person visit, an asynchronous message, or RPM data, will be chosen based on what's clinically appropriate, what the patient prefers, and what's most convenient and effective at that point in their care.
Exactly. You can imagine a patient's journey starting with, say, a virtual screening or triage using an AI chatbot. Then maybe an in-person visit for a definitive diagnosis and physical exam if needed. Subsequent follow-up visits could then perhaps be done virtually. And maybe remote monitoring is used during recovery at home. It all flows together.
Seamlessly switching between virtual and physical. But making that work requires a lot, doesn't it?
It does. It requires robust technical infrastructure, for sure. Telehealth platforms need to integrate seamlessly with electronic health records, EHRs, so all the information is in one place. It requires a significant cultural shift within healthcare organizations, and it requires major investment in training for clinical staff on how to use these tools effectively, and training and support for patients too, to bridge that digital literacy gap we talked about. Engaging all the stakeholders is critical.
Okay. And this brings us back to the policy landscape, especially beyond that 2025 cliff. What needs to happen?
Well, the immediate challenge is clear. Congress really needs to act decisively to make those key Medicare telehealth flexibilities permanent before the September 2025 deadline. Avoiding that policy cliff is job one to prevent a major rollback of access.
Right, maintain the progress. What about longer-term policy needs?
Longer term, we really need a more unified national approach to physician licensure to facilitate safe and effective interstate practice, whether that's through expanding those interstate compacts to include more states and provider types, or perhaps federal legislation that allows for continuity of care for existing patients across state lines. Something needs to make cross-state care less burdensome.
Makes sense for continuity, and reimbursement models need to keep evolving too.
Absolutely.
Yeah.
We need to move beyond just fighting for payment parity within the traditional fee-for-service system. The real goal should be shifting towards value-based payment models that actually incentivize the appropriate choice of modality, virtual or in-person, based on value and outcomes, not just volume. And these models need to provide fair and consistent payment for all forms of virtual care, including asynchronous communication like e-consults and secure messaging and remote patient monitoring, which often fall outside traditional visit-based billing.
So paying for value and outcomes, regardless of whether the care happened in person or remotely?
That's the ideal, yes. Overall, establishing this kind of forward-looking policy framework is absolutely essential. It's what's needed to transform telemedicine from what was, for many, a temporary solution during a crisis into a permanent and truly indispensable pillar of the modern healthcare system.
Okay, so let's try to synthesize this. We've charted telemedicine's journey really from a futuristic concept, almost science fiction in those early drawings,
Right.
to now an integral component of healthcare, a journey that was dramatically, maybe unexpectedly, accelerated by the pandemic. We've uncovered its profound benefits, expanding access, generating cost savings, high patient satisfaction.
But we've also critically examined those interconnected challenges, the real diagnostic limitations, the widening digital divide that threatens equity, the persistent data security risks, and that fragmented, uncertain regulatory landscape, especially with the policy cliff looming.
Exactly. So the thesis seems to hold. The COVID-19 pandemic indeed served as an unprecedented catalyst, forcing rapid adoption and proving the concept at scale. But the future of this healthcare revolution, it's not guaranteed, is it? It's not preordained.
No, its ultimate success really hinges on a collective and strategic effort from policymakers, providers, payers, tech companies, and patients to navigate those inherent challenges thoughtfully and deliberately.
So telemedicine is unequivocally here to stay, and its role will definitely continue to evolve. The future isn't that binary choice, virtual or in person, but rather it's the sophisticated, intelligent hybrid model.
A hybrid model, yeah. One that will be increasingly powered by that next wave of technology we discussed, AI, the Internet of Things, immersive reality, and all of this promises to shift the whole paradigm of care, moving away from being mostly reactive and episodic.
Towards something much more proactive, continuous, and deeply personalized.
That's the vision.
Okay, so maybe a final provocative thought for our listeners to chew on. As technology propels telemedicine forward with AI, IoT, VR, and AR, and as we move towards this integrated hybrid care model, how do we ensure that all the convenience and efficiency we gain doesn't inadvertently dilute something fundamental? Meaning, how do we preserve that deeply personal, trusting relationship between patient and provider? That human connection that has always been such a foundational aspect of effective, compassionate healthcare. How do we keep the care in healthcare, even when it's delivered through a screen?
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.